Necrotizing enterocolitis in infants. The objectives of this PowerPoint are to identify what NEC is, the clinical names, etiology, prevalence, risk factors, prevention, pathophysiology, tests, treatments and procedures, and prognosis. Because necrotizing enterocolitis is such a long and intricate word, in the hospital or clinical setting, you will most likely hear it referred to as NEC. What is NEC? Necrotizing enterocolitis, or NEC, is a bacterial infection of the intestines that primarily affects sick or premature infants. The infection causes necrosis of the intestinal tissue and leads to the development of septicemia. Etiology. Although the exact cause of NEC is still unknown, it is thought that the initiating factor is the introduction of enteral feeds to the premature gut. Enteral feeding is the delivery of nutrients directly into the stomach, duodenum, or jejunum, which can lead to bacterial exposure. The fact that organisms found in NEC babies are also found in healthy babies suggests that damage to the intestinal mucosa is the main underlying problem, resulting in the spread of commensal organisms beyond their normal location. In addition to initiating enteral feeding, other thought causes of NEC are underdeveloped intestines, too little oxygen or blood flow to the intestine at birth, which is usually the result of a difficult delivery, injury to the intestinal lining, heavy growth of bacteria in the intestine that erodes the intestinal wall, and formula feeding. Babies who are breastfed have a lower risk of developing NEC. This is thought to be attributed to the mother's antibodies that the child receives from the breast milk, which are not found in formula. The most common bacterial pathogens that have been found to cause NEC are E. coli, Klebsiella, Staphylococcus epidermidis, and Salmonella. Prevalence. It is estimated that nearly 12% of infants born weighing less than 1,500 grams will develop NEC. Premature infants and infants of extreme low birth weight are at a higher risk of developing NEC due to thin intestinal walls. It is also estimated that only 0.16% of every 1,000 full-term infants will also develop NEC. They're more likely to develop the disorder from a bacterial exposure rather than thin intestinal walls. Risk factors. Like I was saying before, there are different risk factors for preterm infants and full-term infants. Some of the risk factors for preterm are GI immaturity, immature host defense mechanisms, aggressive enteral feedings, PDA, indomethacin therapy, mucosal injury like hypoxemic insults, presence of bacteria within the GI lumen, and NICU overcrowding. As where the risk factors for full-term infants are congenital heart disease, other coexisting conditions such as hypothyroidism, Down syndrome, small bowel atresia, or gastroschisis. Polycythemia is also a risk factor, as well as conditions compromising GI oxygenation and or blood flow. exchange transfusion, perinatal stress, and aggressive enteral feedings. Prevention. The main ways to prevent NEC are the use of human milk versus formula, as so the baby could receive the mom's antibodies, creating a stronger defense against NEC. Neonatal intensive care unit feeding protocols, judicious advancement of enteral feeding between 15 and 25 milliliters per kilogram per day, and the avoidance of hypertonic formulas, hypertonic medications, or contrast agents that may injure the intestinal mucosa and prompt treatment of polycythemia, as well as obviously cutting down on bacterial exposure. Pathophysiology. Through events like hypoxia and enteral feeding, neutrophils and inflammatory mediators are released into the body, along with enteral bacteria. Such mediators include platelet activating factor, tumor necrosis factor, and NO52. The neutrophils, mediators, and opportunistic bacteria all contribute to intestinal tissue injury. When the tissue in the small or large intestine is injured or begins to die off, it causes inflammation that can lead to perforation. Because the infant's intestinal wall is so thin, it eventually becomes unable to hold its contents. Bacteria and other waste products pass through into the infant's body cavity and bloodstream, causing a potential fatal condition known as septicemia. The most common signs and symptoms to look for in a neonate are low or unstable temperatures, not feeding well, dark or bloody stools, increasing gastric aspirates, not digesting food properly, swollen red, tender abdomen, abdominal distension, constipation or diarrhea, visible intestinal loops, and infant becoming less active or lethargic. There are 5 different stages of NEC that are broken down into stage 1, stage 2A, stage 2B, stage 3A, and stage 3B. In stage 1, it's known as suspected NEC. So systemically, there are nonspecific signs such as temperature instability, lethargy, apnea, and bradycardia. They may have gastric residuals and occult blood in the stool, but the abdominal X-ray at this stage will still appear normal with nonspecific changes. Stage 2A, definite and mild NEC, nonspecific signs, abdominal distension plus tenderness, absent bowel sounds, and frank blood in the stool. The abdominal X-ray will show ileus, focal pneumatosis, intestinalis. Stage 2B, definite and moderate NEC. The child will experience mild acidosis or thrombocytopenia. The abdominal wall will have oedema, tenderness, and a mass. And the abdominal X-ray will have extensive pneumatosis intestinalis, early ascites, and intrahepatic portal gas. Stage 3A is advanced NEC. The child will have respiratory and or metabolic acidosis, apnea, hypotension, decreasing urine output, leukopenia, and disseminated intravascular coagulation. Gastrointestinally, they'll have spreading oedema, arrhythmia, and induration of the abdomen. And an X-ray will show prominent ascites with persistent sentinel loop with no perforation. The last stage, stage 3B, is advanced neck as well. However, it'll show deteriorating vital signs, shock, and electrolyte imbalance, as well as perforation of the bowel. Upon assessing a child with neck, you might find respiratory distress or apnea if the abdominal swelling becomes severe or if the infant becomes septic. They'll have bradycardia, hypotension, unstable and or low body temperatures, abdominal distension, abdominal tenderness, redness, ascites. They'll be lethargic, have poor feeding habits, gastric aspirate, abdominal mass, bloody stool, and oliguria. X-ray will be supine and decubitus erect. It will show bowel wall thickening, persistent bowel loops that are filled with gas, and overall gaseous distension. The ABG, depending on the stage of the disorder, will either show metabolic acidosis or acute lactic acidosis. And the labs will show thrombocytopenia and neutropenia. Testing for neck. Ultrasound and abdominal X-ray are the best tests to conclude a diagnosis of neck. On an ultrasound, you're going to look for portal air and areas of walled off perforation or ascites. In the abdominal X-ray, it'll be in supine and decubitus erect. You'll see bowel wall thickening, persistent bowel loops that are filled with gas, and overall gaseous distension. And then an ABG following the ultrasound and abdominal X-ray should show a metabolic acidosis or acute lactic acidosis depending on the stage of the disorder. Treatments. To treat neck, they'll want to temporarily stop all feedings, insert a nasogastric tube to drain air and fluid from the stomach and intestines. Intravenous antibiotics and nutritional fluids will be administered. Frequent X-rays and examinations to determine status of the disease process. And then if the disorder advances into the later stages, possible surgery will be needed for the removal of dead or necrotic bowel and the correction of any perforations. Drugs. Antibiotics, varying depending on the severity of the infection and pathogen. Vasopressors, serious illness may progress to shock and require pharmacologic blood pressure support. Volume expanders, severe illness may experience fluid shifts to the extracellular space, resulting in intravascular depletion that requires expansion. Glucocorticosteroids, which correct adverse adrenal response, as well as hypotension. Antifungals, alters metabolism of DNA and RNA, or an intracellular accumulation of peroxide, which is toxic to the fungal cell. Probiotics, beneficial alteration of intestinal bacterial flora, reducing the risk and severity of the disease, and opioid analgesics for pain management. Corrective surgery, a right transverse incision is made into the abdomen just below the umbilicus. The abdominal cavity is then inspected for necrosis and or perforations. Bloody peritoneal fluid is seen in necrosis, and brown turbid fluid is found in perforation. If the bowel is found to be necrotic, the surgeon will cut out the dead portion. However, if the bowel is not completely dead, the surgeon will leave it in the infant and reevaluate its condition with a second surgery 24 to 48 hours later. If only a small segment of necrotic bowel needs to be removed, the remaining two ends of the intestine are sewn together in a procedure known as a primary anastomosis. If a large segment is removed, or the rest of the intestines do not seem healthy, the surgeon will create two small openings called stomas in the abdomen. The upper end of the intestine is sewn to one opening, allowing bowel movements to exit the body into a plastic pouch attached to the outside of the abdomen. This procedure is known as an ostomy. The role of the RT. Although NEC is not a respiratory disorder, the respiratory therapist still plays a vital role in providing care for the patient. If the infant's abdominal swelling becomes severe, or if the infant progresses into septicemia, the RT must assess the need for oxygen therapy or mechanical ventilation. Initial settings for mechanical ventilation should be volume control due to the restrictive nature of the abdominal swelling. Latest advancements in treatment. Corrective surgeries can now be done laparoscopically. The major benefit of laparoscopic surgery are smaller incisions, less painful, it leaves minimal scarring, has a faster healing time, the images created by the laparoscope are magnified, and that there's a reduced chance for additional infection. Prognosis. Prognosis depends on the severity of each case. Most patients will go on to recover with no lasting effects. As were more serious cases of NEC, patients can experience scarring and narrowing of the bowel that can lead to intestinal blockages or obstructions. In patients who required corrective surgery, like an ostomy or stoma, malabsorption may occur. This is the inability for the bowel to absorb nutrients properly. NEC has a 25% mortality rate. In the year 2012, there were an estimated 342 NEC-related deaths. In conclusion, necrotizing enterocolitis, or NEC, is a serious, potentially life-threatening condition. It occurs when an infant's bowels become compromised and begin to die off, also known as necrotizing. Although the exact etiology remains unknown, it is thought to be caused by the initiation of enteral feedings. The disease is most prevalent in premature infants and can require surgical intervention if not caught early on. While some infants can go on to make full recoveries, others will have lasting side effects, such as malabsorption and bowel obstructions. Sadly, however, 25% of infants with NEC will die. As a respiratory therapy student, I learned that not all patients that we encounter will have respiratory-related conditions. However, it is vital that we familiarize ourselves with all potential conditions, as many have potential respiratory side effects and hazards that we will need to know how to address. The end.